And this is one of my favorite topics, the biliary tract. Is that a little dark? Let's see. Yeah, the biliary tract is a fun topic because it's on every ultrasound, every MR, every CT image of the abdomen. And often doesn't get as much attention as we would like, yet it's one of the most common causes of abdominal pain and has many surgical implications. So we often feel like Homer Simpson when we look at the biliary tract, but as I like to say, at the end of the course or lecture, we like to feel like Margie Simpson, so much smarter. Let's look at the overview. Benign diseases of the biliary tract far more common than malignant diseases, and the most common is stone disease, followed by infection and autoimmune processes, then various injuries that can occur, often, unfortunately, iatrogenic. And then we'll cover the unusual but very deadly malignancies that affect the biliary tract. So let's start off with stone disease, and it's very important because of how common biliary stone disease is. It affects 20% of the population. Although there are risk factors, female, gender, obesity, fertile years, hypercholesterolemia, middle age, the breadth of the disease, it affects children, elderly patients, men, it really doesn't matter. So we recognize the risk factors, but anyone can have stone disease. And it typically looks like this. This is a high-resolution plain film. You can't get higher resolution than plain film of the biliary tract with contrast injected by a percutaneous catheter. And there are two stones in this patient. They are clustered together. They often cluster together. They have facets. Yes, they look geometric. Here's a triangle. This one looks like a trapezoid. They're eccentrically located in the biliary tract. And these are all clues that we can use for cross-sectional imaging to help us make better diagnoses. For example, when I show this case to various radiologists, they'll say, oh, there looks like there's some pneumobilia, but there's also a mass sitting in the hilum of the liver. But when we look more carefully, we recognize that we see a triangle shape here, a trapezoid shape there, a trapezoid shape there. They're stacked one upon each other. They're in the dependent location of the biliary tract, eccentrically located within the biliary tract, and so that these look like stones. And we can confirm on a non-contrast exam that there was no enhancement between the non-contrast and the post-contrast examination. These are typical appearances of biliary stones. They can be different colors, they may be lamellated, but in particular, these are the classic findings that we see. So when we see stones like this, we can see gallstones within the gallbladder. It's very easy to pick out the common duct stones, choledochal lithiasis. Even though there's no bile duct dilatation in the liver, and the common bile duct is normal caliber, less than 7 millimeters. But let's just look at the radiological features of the stone in the common bile duct. It's eccentrically located. It sinks to the bottom, the most dependent portion. There's a crescent of bile anterior to it, the so-called crescent sign. These are all helpful features that we can use. For example, when we look at cases like this. This is a patient with right upper quadrant pain, and it's important to note that only about half of patients who have bile duct obstruction of the common bile duct will have a dilated common bile duct at the time of imaging. So you can see the common bile duct is normal caliber. There's no color difference that we can see. Only a minority of gallstones are actually radio opaque at CT. They're often very similar in color to that of bile. But what do we see? In the heteropancreas, we see what looks like a possible filling defect. But where's the filling defect? It's in a dependent location of the common duct. There's a crescent of gas anterior to this stone, patient prior instrumentation, and those features led us to think there might be a common duct stone. So we followed up with an MRCP. Here's a coronal T2 weighted sequence, and we see not just one stone, but 2, 3 stones, and all stones are dark on T2 weighted images. Not true for T1, but for T2 weighted MR images, they're always dark, and they're clustered together. They have geometric borders, facets on them. Those are common duct stones, choledochal lithiasis. Important to recognize that the common duct, the intrahepatic ducts, are not dilated. which is very common. And so it's not a surprise that choledochothiasis, a common cause of abdominal pain, is often a delayed diagnosis. Sometimes it takes years to make this diagnosis because we're not recognizing the secondary features of these stones. What we often look at are massively dilated ducts. When we see massively dilated ducts, then we have to think that there is a cause of obstruction. So the 3D images that we show to our surgeons, because they look pretty, are not what we use for diagnoses. As radiologists, we always look at the 2D images, the thin sections, 1-2 millimeter slices, whether it's CT or whether it's MRI. It's good to look at the two-dimensional images because we can pick out the filling defects, the shape, the meniscus sign, and the low T2 signal stone on the 2D images that we would miss on the same patient on the 3D images. So we've covered stones, what they look like, but what are other features of bile duct obstruction? Of course, we see bile duct dilatation. And virtually every textbook and every review article will show cases like this, massively dilated intrahepatic ducts, very dilated common hepatic duct, and common bile duct down to a transition point. That's easy, bile duct obstruction. But it's more, much more than just bile duct obstruction. What are our other features of duct obstruction? Well, we can follow the dilated duct downwards. And we can see the meniscus, we can see the obstructing mass or stone. In this case, it's a stone that's the same color as soft tissue. So we can find the offending stone or mass. But beyond that, there are multiple other features that are now recognized for biliary obstruction, including transient hepatic hyperenhancement, particularly in the arterial phase of contrast enhancement. So I think everyone can see in the left lobe of liver, no dilated ducts. In the posterior segment of the right lobe, no dilated ducts. But the anterior right lobe, we can see dilated branching structures, which are dilated ducts. In addition, we see some hyperenhancement of a wedge-shaped area in the liver that corresponds to the area of bile duct obstruction. That is transient hepatic hyperenhancement. What has happened is there's increased interstitial pressure because of duct obstruction in this segment of the liver, and so the less low pressure portal venous flow goes into that liver, and the liver's still alive, it demands blood, so we have higher amounts of arterial flow that goes into that segment of the liver, causing a segmental area of hyperenhancement where we have bile duct obstruction. What else do we see? When we have increased interstitial pressure, we also have increased interstitial edema. And so we will see segmental areas of high T2 signal, or on non-con exam, low T1 or low CT signal in the area of the duct obstruction. And we can, of course, confirm this on the arterial phase of the exam. We see the transient hepatic hyperenhancement on the arterial phase because there's higher interstitial pressure, and so increased arterial flow in acute obstruction. You can also make out some of the or the slightly dilated ducts in this case. What else do we see? We can see absent pneumobilia. If a patient has had prior sphincterotomy or stent placement or reanastomosis of their bile ducts into bowel, they will live their whole lives with pneumobilia. Pneumobilia will float to the most non-dependent portion of the biliary tract. And in this case, we can see very small caliper ducts. They're only slightly dilated. And there's gas in the kind of anterior medial segment of the left lobe of the liver. But the lateral segment of the liver, we don't see the pneumobilia. And so what's going on? Is that duct obstruction? Well, we can, of course, look at the arterial phase of the exam, and we see transient hepatic hyperenhancement in that location. And so we're pretty certain that it's a segmental area of bile duct obstruction causing the hyperemia, causing loss of the air that should be there in this patient with prior instrumentation. And so that's segmental obstruction that can be relieved mechanically with symptomatic relief, with relief for cholangitis using simple ERCP. So it can be treated. Other things we look for, we're not really sure about the time course, it's at least subacute, if not chronic, is atrophy of the liver. And it's very common to actually see incidental left lateral segment atrophy of the liver. And when we see that, we look for the dilated ducts, and we know that was a chronic obstructing process. These patients may require ERCP for brushings because there may be something obstructing either a stone or other process, but it actually seems to occur more often in the left lateral segment. Liver atrophy obviously is a later finding for duct obstruction. And finally, now that we have hepatobiliary agents, there'll be a difference in the uptake of the hepatobiliary agents in the liver parenchyma. So things such as the Eovist, or things such as the CT contrast agents, which is coming back. Was supposed to come back last December, but should be coming back later this summer. For CT imaging, we can see in this case, the patient has had a hepatectomy, reanastomosis of the bile ducts. In the anterior liver, after receiving the hepatobiliary specific agent, cholographin, there's excretion of contrast into the non-dilated ducts of the liver. And in the right posterior duct, we don't see uptake of contrast into the parenchyma. We don't see uptake of contrast into the biliary tract. It was a right posterior segmental branch obstruction that then the surgeon could go in and do spatulation of the bile ducts and reanastomose with relief and return of liver function. And so the hepatobiliary agents add a new dimension to detecting bile duct obstruction. So again, it's not just bile duct obstruction or dilatation, it's many, many features, secondary features that are so useful for diagnosis and cross-sectional imaging. Let's put it together. Do you think this is a bile duct obstruction? Well, we see dilated ducts, we see offending mass, these geometric lamellated structures in the dependent portions of the biliary tract. Here's a cluster. These are intrahepatic biliary stones. We see the transient hepatic hyperenhancement during the arterial phase of enhancement. And so we do have acute obstruction of the posterior ducts in this patient. And this patient has large intrahepatic stones. We have pneumobilia in this case. So it's a case of recurrent pyogenic cholangitis. We see this more in Asia. We do see a fair amount of it in California. There are sporadic cases throughout America. You don't have to have gone to Asia. It tends to occur in kind of middle-aged patients and may be associated with coliform bacterial seeding of the biliary tree in the majority of cases. Minority of cases, there is some type of parasite, Ascaris, Conorchis, etc. But mostly it's gram-negative bacterial seeding of the biliary tract that causes these putty-like stones to recur time and time again for the patient's life. They need to be mechanically removed by ERCP or by percutaneous removal. It's just a pain for these patients to undergo these extractions and recurrent bouts of infection. The imaging features, typically centrally dilated ducts. Peripheral ducts tend not to be dilated as much. The stones tend to be intrahepatic rather than extrahepatic. And they suffer all the complications of cholangitis, intrahepatic biliary abscesses. There may be a predilection for left lobe. I've seen about equal prevalence in left and right. Let's move on. Let's move on to the small duct disease. And the main one that we see in America is primary sclerosing cholangitis. It's a kind of an autoimmune process where the ducts become very fibrotic. The walls of the ducts become very fibrotic. It tends to involve both the intrahepatic and the extrahepatic ducts. We tend to get beaded appearances of the bile ducts with obstruction. The ducts tend never to get particularly large. They're kind of mildly dilated and alternating with areas of strictures. It's a sclerosing process where the ducts collapse on themselves, one of the disappearing duct diseases. This appearance on ERCP looks exactly like ischemic cholangiopathy, such as you might see after embolization of the hepatic artery or after tumor involves the hepatic artery or other cause, radiation to the liver hilum. And it also looks exactly like AIDS cholangiopathy, which was described here in San Francisco, but we really don't see it that often anymore. They look the same, except AIDS cholangiopathy tends to have papillary stenosis as well. It really is mentioned in the same breath as recurrent pyogenic cholangitis, but they don't look alike. Recurrent pyogenic cholangitis has big ducts, and stone. So I really, even though in every textbook it's listed in the same breath, we hardly ever see recurrent pyogenic cholangitis look like primary sclerosing cholangitis or these other small duct, ductopenic small duct diseases. So sclerosing cholangitis occurs typically in young men. It's progressive. Majority of these patients have inflammatory bowel disease, ulcerative colitis, and it's a progressive disease that leads inevitably to liver failure and cirrhosis. They may also have recurrent bacterial cholangitis, and in particular, when we're imaging these patients as radiologists, we do better than the endoscopist because we can look at the whole liver, and we're looking for masses. We're looking for tumors because these patients are at risk for developing deadly cholangiocarcinomas, which need to be treated immediately for any chance of survival. So we look for masses on CT and MR imaging. Other types of cholangitis, ascending cholangitis, there are usually gram-negative bacteria, salmonella, other gram-negative types of bacteria, coliform bacteria. The risk factors are any type of disease, really, of the biliary tract. It could be stone disease, indwelling stents, even tumors, for some reason, can predispose to ascending cholangitis and pancreatitis. We cannot make a definitive diagnosis on cross-sectional imaging. Maybe you can see some mild enhancement of the biliary wall. But Charcot's triad, the clinical findings of pain, fever, and jaundice, especially right upper quadrant pain, helps make the diagnosis of cholangitis. So whenever we suspect cholangitis, we always correlate with clinical features. Let's move on to big duct disease. We talked about one already, recurrent pyogenic cholangitis. And one that we often see incidentally is choledochal cysts. We tend to pick them up in children where we see a large dilatation of the bile duct without particularly much dilatation of the intrahepatic ducts, mild dilatation, but out of proportion, we get dilatation of the common duct or a bulbous portion of the common duct. Again, we show the 3D images to the surgeons, but as radiologists, we'll look at the cross-sectional images because we want to follow the lumen of the common duct all the way down to the papilla. And here we actually see there's a stone, a meniscus sign. It's dark on T2-weighted images. There's a stone that lodged in the common duct because of stasis. But also we want to look at the pancreatic duct. And here's the pancreatic duct coming in, and it inserts on the common duct, and there's more than a centimeter or a centimeter and a half of what we call a common channel. The common bile duct and the pancreatic duct form one duct that then travels for a distance of a centimeter or a centimeter and a half before it implants on the major papilla. That's a problem. That's believed to predispose these patients to develop cholangiocarcinomas. So these patients, they don't just develop it later in life, they develop it in their 30s, in their 40s. So if they're able to disconnect the pancreatic duct from the common bile duct and resect the entire choledochal cyst, the risk of cholangiocarcinoma goes back to background. But if we have the cyst remaining, if we have the common channel, it's believed that that predisposes to cholangiocarcinomas. So there's a whole Todani grading system or classification system of choledochal cysts. Type 1 is fusiform, type 2 is saccular, type 3 is a choledochal seal. It pooches into the duodenum. The diagrams are in your handout. We really don't make a differential, or we don't try to differentiate between these clinically because they all have the same treatment, surgical resection and removal of the common channel. If we just redirect the biliary tract into the duodenum, that does not eliminate the risk of cholangiocarcinoma. And about one case every year, every other year, we're decreasing in frequency. We see a case like this. This is a beautiful 33-year-old woman. As a baby, she had a choledochal cyst. You can imagine, here's the other wall of it, this large choledochal cyst, reanastomosed to her duodenum. They did not resect the entire choledochal cyst. And so she came back at a young age with this enormous cholangiocarcinoma that was then untreatable. So the life expectancy is less than a year. And so really the entire choledochal cyst needs to be resected to reduce the risk of cholangiocarcinoma. And most surgeons recognize that now, but there are still patients floating around with just anastomosis for symptomatic cure. but it doesn't take out their long-term risk. Let's talk about other iatrogenic injuries. Jaundice, abdominal pain, this is an ERCP. We can see the common bile duct with the ERCP, but we can't see the duct above the level of where the gallbladder resection was. That's iatrogenic narrowing of the duct. There may be a leak above the point of the surgical eclipse. So complications of cholecystectomy are, well, they're uncommon, but cholecystectomies are the second most common operation in the abdomen, after a hernia repair, inguinal hernia repair. About 600 to 800,000 of these done every year. A lot of these patients get injury. So we classify the duct injury by the bismuth classification. We have some diagrams. Type 1 means it's just a simple injury, whether it's a leak or a ligation at the common hepatic duct. But most of the ducts are intact otherwise. Type 2 means it's a little bit higher up, near the hilum, but not involving the hilum, the left and right ducts. Type 3 means the surgeon somehow destroyed a large portion of the common hepatic duct. And type 4 means there's involvement of the right or left duct as well as the common hepatic duct, or both. So they're progressively more difficult to treat by surgery. Type 1, we just put a stent in, and the bile duct will heal itself. Whereas type 4, we may need surgery and bile duct reanastomosis to bowel, much more difficult repair. Let's move on to malignancies, gallbladder cancers and cholangiocarcinomas. These are familiar to us because they're such a poor prognosis, but we'll talk about other mimics first. Adenomyomatosis, gallbladder polyps, and then cancers. So in the gallbladder, if we see a little mass, it often makes us nervous. So here's a gallbladder fundus, and there looks like there's a little mass with little, liquid areas within it. Commonly seen by CT, a little bit more than ultrasound, and certainly seen by MR imaging. When we see these little areas of cystic areas within the mass, that makes us comfortable because those are dilated Rotokantschy-Aschoff sinuses. That means it's almost certainly adenomyomatosis, which is a benign occurrence within the gallbladder. It can occur anywhere, but it has a 7% autopsy incidence. This is what it looks like on ultrasound. You can see the cystic areas within the gallbladder, fundus wall thickening. On the MR imaging, you can see here's the normal gallbladder portion, and there's a pinched off portion with little cystic areas, what some people have called the string of pearls appearance. That's benign. These are just benign adenomyomatosis. It doesn't seem to have a particularly high risk of developing malignancy. We don't follow them up at UCSF. We just call it what it is, and the patients go home. Adenomyomatosis is common. It's not a solid lesion, full of little cystic spaces, small cystic spaces. We also don't tend to follow these. We don't see anything on the non-com. On the post-com, we can see a small enhancing lesion. It's a polyp, gallbladder polyp. Gallbladder polyps are not like colon cancer polyps or colon polyps. They don't tend to have that progression from polyp to adenoma to adenocarcinoma. So the majority of these can be left alone unless it's pretty big, unless it's more than a centimeter in diameter, or unless there's some symptoms. But otherwise, they can be safely followed every 3 to 6 months and then one yearly thereafter. It doesn't require a cholecystectomy. But anyway, if they're small size, we just tend to follow them up. I've been following mine for 10 years. Okay, here's another image. This is a plain film. So sometimes you'll see a case drift by your reading room, but you know what the entity is. You just haven't seen that particular modality used on it before. So a typical gallbladder has a very smooth contour. Oh, this one looks really fuzzy and moth-eaten. There's a giant mass in this gallbladder. That's not just gallbladder sludge. It's not round and geometric like stones. That's a tumor. And in this case, it was a gallbladder cancer. So again, a modality you're familiar with, or familiar with, an entity you're familiar with, but the mix of the two can throw you off sometimes. Gallbladder cancers have a terrible prognosis. So less than a 1 year survival in most cases, a 5-year survival of less than 2%, less than 1%. It usually occurs in patients who are predisposed or who have gallstones. The vast majority have gallstones. If you see a tumor without gallstones, you should wonder about a metastasis or some other entity. It's more common in Asia due to chronic infection. What are the risk factors for gallbladder cancer? It's just elderly patient with stones. They tend to be women more than men. They tend to metastasize very early by the time we detect it, because the gallbladder is such a large, floppy source that it takes a big tumor to block the gallbladder. They tend to have peritoneal metastases, so it's important to look for those, as well as GI tract, lymph node, and lung metastases as well. Here's just another example. Gallstones, masses in the gallbladder. We don't see the small cystic spaces, and it's too late for this person. There's already lymphadenopathy. There's already distant spread. This patient will not do well, and we don't have great treatment for gallbladder cancers at the time being. There have been many papers published on differentiating areas of gallbladder wall thickening from gallbladder cancer. I think expert consensus, talking to multiple colleagues, it's just really hard to do it. Even though these papers sound very optimistic, it's just such an infrequent cancer in America that we tend to pick it up late. So these features by MR and ultrasound for differentiating them, they're not very specific. We're not very successful with them. We're a little bit better with bile duct strictures because it obstructs the bile ducts, and the patients get jaundice symptoms earlier on. And we look for malignant features of the bile duct stricture, including abrupt shouldering, eccentric narrowing of the bile duct, longer segment involvement. Those are all typical of malignant features, and they may be cholangiocarcinomas. This is the case of gallbladder cancer with early infiltration of the, or not early, but infiltration of the common duct. Can occasionally be due to other causes. Benign strictures tend to be narrow, gradual, concentric, not eccentric, and tapering, rather than this abrupt narrowing with eccentric shouldering. ERCP diagnosis is good. You have to get biopsy proof, but it's not very sensitive. Likewise, needle biopsy is poorly sensitive. For each pass, it's only about 50% likely that you'll be able to make a diagnosis of cholangiocarcinoma from that sample. And so even if the ERCP brushing is negative and it still looks malignant to us, we'll still say it's suspicious for cancer because the stakes are that high. The 5-year survival, again, is about 2%. So Klatskin's tumor is it's a common form of cholangiocarcinoma. We don't know why cholangiocarcinomas tend to occur right where the right and left ducts come together, but they do, and they cause duct obstruction. Klatskin's tumor is just a name for cholangiocarcinomas that occur in this location. So again, a very poor prognosis, not radiosensitive, not responsive to chemotherapy. Sometimes cholangiocarcinomas can occur in the liver. They look like a mass, but there's very distinct features of cholangiocarcinomas. They will often cause retraction of the liver capsule. So retraction of the liver capsule is because of the scurous nature, the fibrotic nature of this cancer. It's a very tough, hard tumor. Also, there tends to be dilatation of the bile ducts. So if we see bile duct dilatation, we think about cholangiocarcinoma. You can just think of all the liver tumors, malignancies, metastases that you've seen. How often do you see bile duct obstruction? It's uncommon. Occasionally at the liver hilum you can see it, but if you see duct obstruction elsewhere or any duct obstruction, you really want to think about cholangiocarcinomas. Finally, if you see tumors creeping along the bile ducts, that's pretty specific. It's not 100%, but pretty specific for a bile duct primary tumor. Occasionally seen with other tumors, but they're really rare birds, unusual cases. And of course, delayed enhancement because it's a fibrotic tumor. So here's an example, liver contour. We see the capsular retraction, bile duct obstruction, cholangiocarcinoma. Here's another case with bile duct obstruction. We see a tumor creeping along the bile ducts. That's cholangiocarcinoma. One more case, a mass, bile duct obstruction. We think about cholangiocarcinoma, and we see tumor creeping down the common bile duct. So pretty definitive that'll be cholangiocarcinoma. Of course, we get a biopsy to prove it. Okay, we've covered stone disease, the most common cause of bile duct injury, very common cause of abdominal pain. Look for secondary features to make the diagnosis of duct obstruction. We've covered the various types of cholangitis and iatrogenic injuries, and finally the malignancies.